Great to see everyone. Fantastic turnout, 67 people at the moment. My name's Richard Blackwell. I'm Associate Director of Insight at the Health Innovation Southwest, and all I'm here to do today is introduce Simon and take some questions at the end. So we'll have half an hour talk from Simon first off, and then I'll try and deal with the questions at the end. So Simon is a consultant in public health at Devon County Council, and I'll hand over to you for the talk.
Okay, so yeah, thanks for the introduction, Richard, and just to kind of take you over what I'll be discussing today. So my background is in public health, but primarily before I was a consultant in public health intelligence. So I've done a lot of work over the years in terms of data and kind of linkages and looking at data across our various organisations, local authorities in the NHS. So what I'll be presenting today takes you through one of the things we've been doing in Devon, which is looking at linked data for population health. So I'm going to take you through a little bit around what linked data is in this context, what it's used for, and then also kind of take you through kind of our experience in Devon and how we've kind of arrived at where we are now. So I'll kind of give you some examples of what we've done with our One Devon Dataset, which is our local linked dataset, and our plans going into the future, and then we'll open up at the end into a discussion. So starting off, what is linked data? So this is about generating a single view of data around individuals or communities, which in this context combines healthcare and population data. So it's about basically bringing those different data sets together with identifiers to be able to kind of join them and link them so you can form that holistic view. We've got a very simple example on the right hand side here, which is data linkage around birth registrations and hospital activity. So this is from HDR UK. So you can see there how different data from clinical systems, from birth registration, and also from different notifications and demographic data comes together, and how that's then linked around details like NHS numbers, mother's date of birth and NHS number, home postcode, and so on, to create those data linkages across. And these links can be based on those kind of person, household and geographic identifiers. So different ways of being able to kind of link there. And a process called pseudonymization, which some of you might be familiar with, is how you then turn those identifiable fields into fields which are no longer identifiable. So a pseudonym instead of NHS number, which will allow you to identify an individual across systems without knowing personal identifiable details, but also aggregating from date of birth into age and years, postcodes being aggregated up to avoid that direct identification. Within linked datasets as well, you tend to have re-identification processes. So your analysis is done in that pseudonymized or even anonymized data, but then for direct care purposes, you have means to re-identify. So for particular interventions, cohorts and individuals can be identified. And the benefits of doing this are many and varied. So first off here is identifying those interdependencies between different services. So it's understanding where someone may be presenting with a condition, with a health problem, and then how that impacts on different services. And being able to do this allows us to look at that flow, look at those connections, and also look at people's touch points with services over time, so we can start to understand that pathway, understand that pattern. It's about joining the dots as well. So we may have data, for example, on dementia diagnosis and carers, which may be held in different places. Some of it might be in a primary care record, some of it might be in mental health providers, some of it might be in social care providers. So being able to combine that information and do some work there to improve diagnosis rates, for instance, is another place where this can come in. It's looking at the system as a whole as well. So that's about looking at those kind of wider system outcomes. It's looking at inequalities, both in terms of geography, but also in terms of particular kind of groups in the population, personal and protected characteristics and so on, but then understanding that overall pattern around system usage and costs. So rather than looking in our individual service areas, it's about getting that holistic view, as it were, and being able to then monitor and model the impact of different interventions, as well as evaluating what's happened as a result of interventions being put in place is another place where they really come into the fore. Okay, so talk about population health as well. So many of you will be familiar in some way with this as a concept, but we've got two definitions here. Top right hand is population health. So this is, I think, from the King's Fund, and what you're talking about there is an approach which is aimed at improving the health of the overall population. It's about looking at physical and mental health and also reducing health inequalities. And then you'll see addressing the wider determinants of health, so those factors in the community and in the wider environment which can impact on health as being key there. Population health management is what you do with this data, these data to basically drive interventions, drive the planning and delivery of those using approaches like segmentation, risk stratification and modelling to do that, and then targeting particular cohorts. So it's all the kind of data management. Now you'll find that population health and public health get used somewhat interchangeably, and I think the important thing to note there is that population health is quite a useful concept, because what it highlights is work around prevention, work around addressing the wider determinants of health, and work around reducing inequalities is the work of everyone. It's not just around a particular service or a particular discipline like public health. It's something we can do as a whole across healthcare and wellbeing partnerships. So I think that's one of the keys there. There's a few other specific details down the bottom which I won't go into detail on now, but you'll kind of see from that it kind of reflects the various aspects and the importance of that kind of working together across wider partnerships. In terms of how integrated care systems work on this, there's a number of prerequisites. These are drawn from something originally known as the Population Health Management Flat Pack. So this was produced by Imperial College in London. It's been somewhat adapted over the years and used quite extensively by NHS England, and particularly in relation to the programme which they have in place for population health management development, but it kind of picks up these areas which you need and these prerequisites that you need as a system to be able to do this effectively. So infrastructure is all about having the systems and the organisational factors in place which will kind of allow you to operate in this way. Information governance and having the right data infrastructure is really important there. In terms of intelligence, it's about having the tools and the intelligence functions working together and working effectively to allow you to do all this work. So that's more about that kind of skills and capabilities, really. Interventions, it's about having an approach to citizen involvement in care model design, which kind of integrates these kind of various aspects around prevention, early intervention and evaluation. So it's about having, let's say, a kind of approach in mind which focuses on that. And finally, incentives, it's having the right drivers, the right enablers in the kind of wider system to allow you to kind of operate in these different ways. Okay, so carrying on, there's kind of various routes which local systems can follow to basically derive their own linked data sets, and I've got three of the main ones listed out there. Now, one is kind of a shared care record, so where local systems have that in place, they can sometimes form the basis for linked data for population health management work. This is a highly robust and integrated way of doing this, and it's clearly aligned to those direct care purposes as well, can sometimes be limited around the wider determinants of health and those kind of other wider factors which we might fit in there as its care record base. So that's worth bearing in mind there. The two other routes, so commissioning support unit or DSR CRO. So these are the regional and sub-regional kind of data teams providing this support, and many of those are kind of set up to provide linked data solutions and are doing this for local systems and local areas. So one of the benefits there is the data linkage is all happening in that central location, but the downside to an extent is that kind of local control and flexibility. So in terms of adaptions, it can take a little bit longer time, and it can be a bit more of a kind of involved process to get there. In terms of local data flows, this is about having nominated data controllers in the local system, and that data flowing within the local system from the various service providers and data suppliers, and then that's kind of coordinated centrally. So that's more in terms of local management, but what you also have there is a bit more local control. There's various things in development which I won't go into detail now, such as the secure data environment and the federated data platform, which both around the work of integrated care systems, but also kind of reaching out into the kind of research realm as well, offer a wide range of possibilities going forwards. So worth acknowledging those, but that's a whole separate matter, and I think you've probably heard about those separately anyway. So and also worth mentioning that there are additional linked data routes for research, including some kind of national sources there, ADR UK, for example, but there are many others in that space too. So I'm not talking about those specifically. Okay, so I'm just going to take you through a bit of our kind of potted history in Devon before going into some of the details of our One Devon dataset. So starting off in terms of having that kind of data set for Devon, Plymouth and Torbay, that whole picture. The first gem of that as an idea was 2017, and that itself was driven by kind of various local projects, including one in Integrated Care Exeter, which linked some of the GP, secondary care and social care data. So and really from 2017 through to 2019, there's a lot of time and quite a long process in terms of establishing the principles and gaining that wider system support for One Devon dataset. So a lot to kind of process and think about there in terms of kind of organisations, what they would do with the data, and actually getting the kind of right infrastructure and documentation in place to enable everyone to do that. So quite a lengthy process, but that is not unusual, and I'll say more about that a little bit later on. So in terms of getting the data set established, that happened in 2020, so very early 2020. We had the data set kind of pulled together, mainly focused on 5 primary care network areas out of our 31 across the whole of Devon, but also kind of linking the data from the mental health community, healthcare and acute trust providers alongside adult social care. So that was kind of first established there. It was for an NHS program called Population Health Management Development Program. So we kind of took part in that in 2020 into 2021. So that was the first and main purpose for bringing that data together. And then from then onwards, from kind of 2021, we established and started developing the kind of further local applications and really embedding what we were doing within the Population Health Management Development Programme. So we devised a roadmap to how we would do this, and we developed the information governance documentation. So we pulled in the full range of approved uses for linked dataset, which is set out in something called the Secondary Uses Data Guidance Tool. So I'll say more about that a little bit later. And it also established both the clinical commissioning group as it was then, integrated care board now, and our local authorities in Plymouth, Torbay and Devon as joint controllers of the data set. Then in 2022, we kind of further expanded that information governance documentation to give us the re-identification purposes for direct patient care, and also established that use request board, so new requests for data beyond that population health management core could be considered and approved. So more about that in a little while as well. 2023, that was really about getting these kind of processes in place and fully flowing, which they are. And this year it's about continuing those uses and the development of the data set accordingly. And I'll take you through some of our kind of future plans as we get through this. So in terms of the overview of the One Devon Dataset, this diagram here just represents the main components, the main sources of data feeding in at present. So you'll see there we've got adult social care, we've got mental health providers, so that's Devon Partnership Trust and Live Well South West. We have community healthcare and acute trusts, so that will include inpatient, outpatient and urgent care information, and we've got general practice feeding in there. You've also got that link to wide determinants, so using the kind of common pseudonym and things like indices of deprivation, different area classification tools, and information around demographics, protected characteristics and so on, so we can really use this to its full extent around understanding inequalities. You'll see the greyed out circle there in terms of coming soon are data sets which are not there at the minute, but we're working on and developing to bring into this environment. Most there is children's services, education, child health data. So filling in some of those gaps. So we've got adult social care at the minute. We don't have children's social care, but that is something we're very actively working on at the minute, and we'll be developing over the next year. In terms of completeness, we've got all the different providers signed up in terms of those larger providers, and we've got around 80% of practices currently signed up across Devon. There's a few who are kind of still to sign up, but with that 80%, it would give us a coverage of, I think, just under a million, about 900,000 to a million. I don't remember figures off the top of my head, but quite a significant population there. And in terms of that data, it's linked, it's costed, segmented and stratified. The time coverage varies a little bit, but they're typically all 5 years plus, sometimes running up to 10 years or more, depending on the exact source. And just to mention the partners, so we've got them listed out here. I've already mentioned the data controllers in terms of the integrated care board and the local authorities there. And you'll see the various healthcare trusts and also the GP practices within the wider area as well. Okay, and running on, so I'm not going to read this out in detail, don't worry, but here's just a very quick flavour of the One Devon Dataset data field. So we've got the various sources down the left-hand side there, and in the right-hand column, we've got the kind of various data fields. So there's a whole range of things in terms of identifying providers, their locations and their sites, but also looking at outcomes, costs, treatments, prescribing, and so on. The demographic, geographic row at the top is quite important because that kind of picks up the various identifiers. So we have things like pseudonym, age, sex, ethnicity, featuring there, but we also have those lower geographic building blocks. So we use the census output area, which is I think around 120 households per output area, around 250 to 300 populations, so that gives us a street level view to build on. But we also have kind of flags in there for particular types of locations, so people living in park homes in more kind of temporary residential accommodation, which is really important for health inequalities in Devon, but also identifying those in care homes, as well as having in terms of demographic segmentation, mosaic group and type. Okay, And that geographic hierarchy, this just gives you a bit more of a view into that and how it works. So we've got what we'd consider to be the ONS hierarchy there. That's the Office for National Statistics. So that takes us from county level down to those local authority districts. So we've got kind of 8 of those within the Devon County Council area, down into these output area levels. So we've got the census output areas I've mentioned at that kind of lowest level. So you'll see in the bottom right hand map there, that kind of more street level view. But then above that, you've got lower super output areas and middle super output areas. And these are kind of useful because various data sets are released nationally on these. So that gives us a means to bring in some of that local geographic data as well. And being able to kind of use this as well to group into indices of deprivation, urban and rural classifications, and also the Office for National Statistics area classification gives us further means to understand some of those geographic variations and inequalities, particularly when we're looking at areas of a similar type. Okay, so I mentioned this, the secondary uses data governance tool, and these are the defined purposes which you can use linked data for. And what we've done in our local documentation is included all these. So I won't read these out, but we've got 4 blocks here. One is around planning, implementing and evaluating population health strategy. So wide range of things around risk stratification, reviewing and evaluating services and understanding wider determinants of health. We've got a block there in the bottom left for risk stratification for early intervention and prevention. So identifying risk scores and using that to identify individuals and groups within those cohorts. Then that central block is around undertaking research. So there's a variety of things there around identifying and managing research cohorts, but then also undertaking studies and developing different tools and integrating additional data sources. And then on the right-hand side, we've got managing finances, quality and outcomes. So various things there around economic and also kind of outcome-based monitoring. So again, I won't read all those out, but they're there and cover a wide range of different activities. In terms of information governance, so I've mentioned the re-identification for direct care purposes. What's important as well is being able to remove people who have opted out. So we've got robust processes in place to allow us to do that. In terms of maintaining confidentiality, that's tied up both within that kind of data set and how it works. But also around having disclosure controls in place for any published data. So we use the national guidance there to set limits and assure ourselves that no data relating to small counts or small areas is coming out which doesn't accord with guidance. And beyond that, we have a full suite of documentation in terms of joint controller agreements, information sharing agreement, and data protection impact assessment. Okay, so a little bit around governance now. So we have 2 main groups, the first of which is the One Devon Dataset Development Group. So this consists of mainly people in intelligence roles. So it's got business intelligence from the NHS, it's got public health, and it's also got our One Devon Dataset librarian, and that's chaired by Kelvin Grabman, who's the Director of Business Intelligence for the ICS. This connects as well with various committees within the ICS, including the Population Health Management Improvement Committee and the Data and Digital Transformation Group. So kind of it sits and has a relationship alongside those groups, which sets some of that overall system direction as well. The steering group is about kind of overseeing and maintaining that data set and doing those data quality checks and acting in that assurance role to make sure everything is running effectively and efficiently. The other main group is the use request board. So any uses of the One Devon dataset will go through this group, and that's kind of chaired by myself. And within that, we've got quite a diverse membership. So we've got information governance lead, we've got a lay member who is from Health Watch, and we have GP, secondary care, local authority leads, as well as having some of the intelligence and technical leads in there. The One Devon Dataset librarian as well sits within that group and coordinates and receives those inquiries for the use of the dataset and also the use request forms. So in terms of that board does, it approves the process around which these use requests are considered, and then it will consider those individual requests on a monthly basis, and it will kind of use the kind of various experts in the room to look at it from those kind of legal, ethical, equitable and kind of practical perspectives. And that's all about making sure that the use is consistent with the documentation and accords with system priorities. It also will specify any conditions of use which might need to come into force, and also receiving the approved outputs back before wider circulation. So there's a bit of a verification process in terms of making sure that the actual use accords with what was agreed, but also it's about system learning. It's about having that kind of feedback loop and kind of understanding how the data is being used and what it has informed. Okay, so I've got a few examples now of approved use cases. So the population health management action learning sets, in terms of the work we've done through development groups to bring different groups together, identify cohorts and target interventions, is one of the main ones there. But there's a whole variety of other uses, and this is just a small sample. I think we've probably had about 50 or 60 use cases through at this stage, so quite a few there, but covering a wide variety of different areas. Health checks around learning disability and serious mental illness. As an example, dementia diagnosis and making that kind of linkage between mental health and primary care services. A lot of work around seasonal vaccination programs, both for COVID and flu, in terms of supporting GP practice and increasing uptake, but then also a variety of other more kind of needs assessment and inequality based applications. So we've got work ongoing at present around fuel poverty and stratifying risk based on housing conditions, but also looking at health and wellbeing of care experienced young people for a health needs assessment, which is happening in the County Council. And this slide just gives a little bit of further detail around one of those. So this is around the PHM action learning sets. These learning sets were bringing together primary care networks with integrated care system and wider community partners, and about identifying those cohorts and developing interventions. We've done 2 runs of those so far, one in the initial population health management development programme in 2020-21, and then more recently with that expanded list of primary care networks in GP practices in 2022 into 2023. And these are focused in a number of different areas. North Devon Flow is quite a good example. So that's a person-centred, multidisciplinary kind of support mechanism, which is based up in North Devon, which has had a kind of ongoing life beyond its origination in the first action learning sets in 2020-21, and that was around kind of understanding those flows, but a wide variety of other work around frailty prevention, complex lives, suicide prevention, dependency forming medications and so on. What we found with these action learning sets is that they tended to focus on very kind of upstream kind of prevention focused cohorts. So there've been throughout all of them a focus on inequalities around those wider determinants of health, around understanding complexity, and also including mental health alongside physical health within the cohorts and within the kind of purpose of interventions developed. So from a public health perspective, that was very good to see. So applications, so I've got some specific ones here around research and valuation. So first note there is that research applications require integrated care system involvement. So it would require one of those partners outlined earlier in terms of those main NHS organisations, local authorities, GP practices to be involved in a research project. And In terms of the approved research applications to date, we've done a social prescribing impact evaluation. So that's initial work done and a kind of ongoing project within Exeter to take that forward. We've also got a project called Inequalities in Research Participation, which is through the NIHR REND programme. So I'll say more about that in a second. We recently approved a use request around prediction of stroke via machine learning. So that's an MRC funded project. And we also have one around functional neurology and economic evaluation, and various ones in development. So a couple just to mention there is around low traffic neighbourhoods evaluation, and also looking at inequalities in dementia diagnosis. So a couple of those relating to research. And with these, the data processing happens within those integrated care system joint controllers, but we're currently developing those kind of placement options as a way of bringing in staff and expertise to work on these projects for those cross projects across local partnerships. So that's something else which is very active in our world at the minute. So and yeah, just to mention a bit more around the Inequalities in Research Participation project. So this was linking data on research participation from our acute trusts to the geographic, personal, social and clinical characteristics in the One Devon Dataset. And this was all around saying and finding out, are there people who are underrepresented in terms of participants and people who are kind of active in research? And this analysis and bringing these data sets together allowed us to kind of answer those questions locally. And what we found was lower participation in those with mental health and learning disabilities. And we also saw lower participation in males, younger age groups, ethnically diverse groups, deprived communities, and rural and remote areas. And this initial data analysis, and this is a project which is ongoing, I think heading into its third wave in terms of kind of funding and activities, provided the basis for actually defining those kind of cohorts and targeting activity around those particular groups to increase participation. And that's been kind of working across community and voluntary sector partners as well as the local integrated care system. So some quick reflections now on the Devon experience. So first one is that you move at the speed of trust of the most cautious partner. So you'll note what I said earlier about that kind of long period to get from 2017 to 2019, pulling the One Devon Dataset together. And that's because you need to really get to the place as a system to be able to do this. And that's about having the right processes, but also having the kind of trust between the various partners to do this, and having good system leadership to do that. I think progression towards linked data sets is one of the best signs of integrated care system maturity that you have out there. So I'd always use that as a gauge to look at how effectively a local system is operating. Applications as well are a very useful mechanism to improve data quality. So as we do work in these areas, we're often kind of touching on some new ground. So using the application to be able to both assess and then improve data quality is really important. And development of a linked data set tends to be incremental as well. So you'll see from the staging how we progress towards the One Devon data set. And both with applications and data suppliers and different data sets, you need to kind of build that as it goes. And then that momentum, once you have built it in the local system, does build very quickly. So from establishing the use request board, we very quickly got to doing those use requests, and actually the kind of from the system, the demand for the usage, but also the maturity of the requests growing quite rapidly. as we've gone through that, and really picking up on good ideas from elsewhere as well. So we shouldn't be competitive about this. We should really seek to learn and grow from others, and we have things like the NHS Futures platform, which allows us to kind of connect with others, and naturally kind of events and talks like this, and other things SWAIH do, which yeah, just to allow us to really gauge and compare and share what we've been doing in our various areas. So getting independent input into information governance, advice and support is really important as well. We've got a kind of good relationship with some external support around doing that, and getting a system rather than an individual organisational perspective is really important there. And local authorities being actively involved really does kind of come to the fore as well. A local solution can take a long time, but the adaptability as well that we've seen in Devon is very useful. So whilst it took us a long time getting there, I think, yeah, in terms of where we are now and where we might move forwards to, it gives us a range of possibilities, and I think some greater control over our own future. In terms of those, just before I finish, just a few points about where we're heading next, and things like the Joint Forward Plan, our Population Health Improvement Committee, and use requests will influence what we prioritise within the One Devon Dataset in terms of aspects we want to take forward. One of the first and foremost things at the minute is looking at household identifiers and bringing in a pseudo unique property reference number. And what that allows you to do is bring in factors relating to a household. So that might be looking at family and familial risk factors, but it might also be looking at locational risk. So looking at things like housing conditions and the built environment. Dataset development. So I've already mentioned children and young people's focus first. So building in that dataset, and our current application around care experienced young people and children in care will be a first foray into that, and further work as well around carers and understanding the health needs of unpaid carers. So within all this, it's about also kind of making sure your processes and paperwork are up to date to facilitate all that. So yeah, that's it for me in terms of an overview of our experience in Devon, and yeah, opening it up to any questions really.
Thanks, Simon. It's fantastic. Lot in there. And just for everyone's benefit, there was a huge amount of work which went into the One Devon dataset. It sounds like it was quite simple. The amount of work that these folk have put in, it is fantastic. So yes, much appreciated, Simon.